Well, good afternoon, and thanks, Jonathan, for adding me to the program. Much appreciated. Just as a starting point, we're going to be talking about high-risk disease. Again, a number of definitions for high-risk prostate cancer. We'll stick with an easy one, not necessarily the best one, but an easy one in terms of factors based on clinical staging PSA and biopsy Gleason score. Of course, high risk simply means that if these patients are treated with local therapy alone, they have a high risk of failure, biochemical recurrence, and then progression to clinical endpoints. Now, as Dr. Carroll mentioned in his presentation, until relatively recently, most of these patients were managed with radiation therapy. Surgery was somewhat reserved for the low-risk patients, and the higher-risk patients were managed with radiation therapy. And certainly, radiation oncology has done an excellent job in terms of performing clinical trials. They've shown that the addition of radiation to hormonal therapy is better than hormonal therapy alone. Dr. Zalewski addressed the issues of dose and increasing doses in improving outcomes in intermediate and higher risk patients, and certainly the combination of hormonal therapy plus radiation being superior to radiation alone in patients with high-risk disease. So certainly a very well-defined treatment strategy for high-risk patients managed with radiation therapy. So why wasn't surgery used until relatively recently in these patients? Well, certainly there were concerns about quality of life. Are these bulkier, higher-risk cancers associated with higher risks of intraoperative and postoperative complications such as incontinence and erectile dysfunction? Were you more likely to injure a ureter or the rectum? And there were concerns, of course, about high rates of biochemical recurrence. Now, I'm not going to go into all of the data, but most of the studies these days have shown that radical prostatectomy can be performed safely whether the patient is high, intermediate, or low risk. There certainly are complications, but the higher risk of disease is not associated with a higher risk of at least intraoperative complications. The surgery can be performed safely. Rates of incontinence are independent of risk of disease. Certainly there is incontinence, but it is not based on whether the patient has an intermediate or a higher risk cancer. Certainly rates of erectile dysfunction are higher. We do not do as much bilateral complete neurovascular bundle preservation in patients with higher risk disease, but as Dr. Ledone pointed out, it's not universal that these patients end up with erectile dysfunction. At least in our series, about half the patients, somewhere between a third and a half of the patients by 2 years after surgery that were potent before surgery end up with functional erections defined as an IIEF of greater than 21, most men using one of the oral agents. So it's not universal that these higher risk patients end up with erectile dysfunction, although their likelihood is higher than men with intermediate risk disease. And finally, by definition, these patients are at higher risk for biochemical recurrence. And if you look at our surgical data, this is the curve for higher risk disease. At least half of the patients will experience a detectable PSA following radical prostatectomy. This does not, however, translate into such a bad prostate cancer-specific mortality. So at 15 years after surgery, only 19% of the high-risk population has died of disease. Most of the patients, there's at least almost 1.5 times of the patients that have died from other causes. So while PSA failure rates, biochemical recurrence rates, are quite high, patients can receive additional therapies such as salvage or adjuvant radiation, potentially curative in some, and then with improvements in systemic therapies, these patients certainly have an excellent, what I would think in a high-risk population, prostate cancer-specific survival. So if one was simply to put on their surgeon's hat, I'll put on my radiation oncology hat in a second, and one was arguing from the surgeon's viewpoint why surgery should be used rather than radiation therapy, one of the arguments would be, well, we don't have to use long-term hormonal therapy. You don't have the nasty effects of hormone hormones, which we know are quite miserable, certainly more miserable than surgery or radiation itself. You get a pathologic assessment. You can microscopically see the extent of cancer, better risk stratify. You can address the lymph nodes. Whether or not that's beneficial, that's up for argument, but you can make the claim that we can remove lymph nodes and perhaps benefit the patient. Recurrence is certainly easier to detect after surgery. Your PSA is either non-detectable or it isn't, whereas there are some shades of gray with radiation therapy. And if one does experience a recurrence, there are better, in quotations, salvage options. You certainly can receive salvage radiation therapy, which is potentially curative, whereas the salvage options after failed radiation therapy are quite limited, and if you go through them, they're quite miserable. And then finally, surgery provides excellent local control. Very few patients develop outlet obstruction or ureteric obstruction because of local growth of cancer after radical prostatectomy, whereas patients who receive radiation therapy are at higher risk for symptomatic local recurrence. Now, radiation oncologists certainly have their take on things, and it's a very reasonable take. The advantage of radiation is you don't have to go through that miserable surgery. You don't get stabbed 6 times to have a robotic operation. You don't have a catheter for a week. Incontinence, my God, why would you accept that? So simply going through the treatment favors radiation therapy because there's no restrictions. Pathologic assessment, who cares? We base everything on what your PSA does anyway, so why do we need the microscopic assessment of your tissues? It really doesn't impact treatment decisions. While recurrences are easier to detect after surgery, it's because most patients recur and you're going to need radiation anyway. So why not just have radiation up front and avoid that miserable operation? There are salvage options if you fail radiation. We do salvage radiation therapy. There's cryotherapy. There's other ablation type techniques that work very well. And with modern day high dose radiation therapy, local recurrences are quite rare. So you don't have to worry about these symptomatic recurrences. So again, the argument is ongoing, and I doubt we will ever have a good clinical trial that answers this question. And as was mentioned, surgery is not for everyone, radiation's not for everyone, and individual patients will value things differently, and it's good that they have choices. Sometimes it's bad for them that they have choices, but there are choices. So one of the issues with radiation therapy in the high-risk setting is that standard of care is with hormonal therapy. Systemic therapy is a standard of care with radiation. Why not with radical prostatectomy? Well, the studies that were done, not powered for clinical metastasis or death from prostate cancer, and relatively short-term hormonal therapy. Most of the studies were 3 months. There's one study from Canada that went out to 8 months. And while there were histologic differences in the radical prostatectomy specimen, longer-term follow-up showed no difference in biochemical or clinical recurrence rates. So that's why hormonal therapy is not a standard of care with surgery. In fact, most of the guidelines say that it shouldn't be used and that it doesn't provide any particular benefit. Dr. Thompson ran one of the very elegant adjuvant radiation therapy trials. There's a few others out there that have shown that adjuvant radiation therapy provides up to a survival benefit in the Southwest Oncology Group study, more so than observation or perhaps more delayed radiation therapy than early salvage. But the debate continues regardless of this randomized data, whether adjuvant is better than early salvage. We don't know that. There's some studies looking at that. But I would venture to say that in the United States, most patients are treated with salvage rather than adjuvant radiation therapy. We also have a randomized trial in patients with positive lymph nodes, the Messing study, that adjuvant hormonal therapy improves survival. Again, a relatively small study, and most patients these days are managed based on their PSA. They don't receive adjuvant hormonal therapy even in the setting of positive nodes. So in the adjuvant and neoadjuvant world of radical prostatectomy, despite the data that's out there, most men don't receive neoadjuvant treatment unless they're part of a clinical trial, and they don't receive adjuvant treatment because we follow their PSAs. So what about non-hormonal based agents? The concept of androgen annihilation, meaning using some of the more potent hormonal agents that have been developed recently. And to tag on a little bit to Dr. Kantoff's study, what about genetic guided therapy? So from a non-hormonal based strategy, this trial has been mentioned a couple of times today. It's now the Alliance, but originally the CALGB 90203, the PUNCH study. And it basically randomized patients with high-risk prostate cancer to either radical prostatectomy alone or neoadjuvant chemo-hormonal therapy with docetaxel, followed by radical prostatectomy, asking the question, does neoadjuvant chemo-hormonal therapy provide a benefit? The first readout will be biochemical recurrence rates at 3 years. That should come next year. So we enrolled the last patient a few years ago. We have to wait till they're 3 years out from their treatment. Don't know the answer yet. All I can tell you is that the Data Safety and Monitoring Board did not close the trial early for excess toxicity, so the patients seemed to tolerate the treatments similarly, and there was no either futility or grand slam in terms of outcomes. They didn't close the study because either there was no sign of benefit or that the benefit was so great that we should stop the study early and start using combination therapy. We'll know more about that hopefully early next year as the data matures. From the standpoint of androgen annihilation, this is getting a lot of evaluation in clinical trials. This is from Mary Ellen Taplin, borrowed one of her slides. Basically, this is a combination of abiraterone, enzalutamide, and LHRH, pre-radical prostatectomy, looking at a histologic endpoint. I think as time has gone on and they've added more patients, the pathologic complete response rate isn't quite a third of the patients. It's more 20 or 25%. But still, we had not seen pathologic complete responses in any other neoadjuvant studies that we've done. I don't think we've seen them in any of our chemotherapy phase 1-2 studies. Certainly, there were a few in the 8-month duration of LHRH agonist trial from Canada, but nowhere near a 20 to 25% pathologic complete response rate. So hopefully these combination studies will get more patients and more evaluation, and again, relying on some of the genetic tests that are available to perhaps select the patients who may most benefit from this particular combination. And we just heard about BRCA1, BRCA2, the DNA mismatch repair genes, and certainly they're important because we have a drug that can target them. Some of these slides you saw with Dr. Kantoff's talk, we learned about PARP inhibitors and the like. So one can imagine that one does a genetic study of the patient's either germline or somatic mutation analysis, find out where there are particular targets. That patient will be shuttled to some form of systemic therapy plus a local treatment, be it radiation or surgery, and that's how we'll manage prostate cancer, hopefully not in the too distant future. But certainly adding systemic therapy to good local therapy will improve outcomes. And whether the local therapy is radiation or surgery, hopefully that can be defined genetically or based on what your question is in your clinical trial. So just to sum up in this presentation, from the standpoint of looking at treating patients who were considered incurable. So if we were taking our urology boards and we were asked, how do you treat a patient that has obvious metastatic disease from prostate cancer, and we would say, take the prostate out, they would escort us out of the hotel and ask us to do anesthesia. It's not considered what we do. Metastatic disease is a systemic disease. You treat it with systemic therapy, period. All of the guidelines, hormonal therapy is the primary mode of therapy. There is no mention of surgery or radiation unless it's to the symptomatic patient who would receive radiation therapy. But There is a suggestion in other diseases, some of which we treat, some in other disciplines, that actually treating the primary cancer with systemic therapy actually improves outcomes. This is just a smattering of studies. We're most familiar with the renal cell data, but ovarian, colon, et cetera, shows that combinations of treatment work better than just the systemic therapy. Now, one can argue why that is, but certainly the data is the data, at least in these disease sites. Retrospectively, looking at large databases, this is a SEER study done by Culp. Again, obvious questions about selection bias and the like, but patients with metastatic disease at diagnosis, a very small percentage of them, less than 5%, had their primary cancer treated either with surgery or radiation. Don't know why. So again, selection bias, but those patients who received local therapy did better in terms of 5-year disease survival than those patients treated with hormonal or systemic therapy alone. So again, suggestive that perhaps treating the primary may provide an advantage. This is a study from Axel Heidenreich in Germany, not randomized, and it's not quite clear why some patients received radical prostatectomy and others did not. But basically, patients were treated who were diagnosed with low-volume metastatic disease, less than or equal to 3 bony mets, no bulky adenopathy, no visceral disease. They were treated with androgen deprivation therapy for 6 months. If their PSA went below 1, they were considered in this analysis. Some underwent radical prostatectomy, some had no radical prostatectomy. And what you can see is that the time to castrate resistance, the time to clinical progression, cancer-specific survival, and local surgical palliation defined as, does this patient need a TURP, a PERC tube, a stent, anything that would require a surgery to manage, those all favored the group that had undergone surgery. Again, interesting data. I don't think it means that we should be performing radical prostatectomy in everyone with metastatic disease. So what we're trying to do here is look for a treatment strategy combining local and systemic therapies to try to improve outcomes or even potentially cure some patients who are diagnosed with metastatic disease, all on study. So the patient will have been diagnosed, they start their systemic therapy, which they receive as a run-in, they get their local treatment, which in this particular study, because of the endpoint, the primary is treated with surgery, meaning radical prostatectomy. Sites of metastases, bone metastases typically, are treated with stereotactic body radiation. The systemic therapy is continued for a finite period of time. Then the patients are observed, their testosterone will recover, and the endpoint, which is why we chose surgery, is a non-detectable PSA in the face of a normal testosterone about 2 years after therapy. So this will give a hint that this combination, whatever we use, is worth taking into larger studies. So basically a quicker drug screening strategy to try to identify things. And a la STAMPEDE, we can add systemic therapies and build on what's been done at the Brigham, where they found that enzalutamide and abiraterone had some pathologic complete responses. We can do that. We can add other systemic therapies. We can say if you have particular gene mutation A, B, or C, you get randomized into the arm that gets the drug that impacts that particular abnormality. So a building strategy for combining local and systemic therapy, and hopefully we'll find a combination that, at least in selected patients, can cure what is considered to be incurable disease. So in the setting of metastatic disease, it's certainly not for everyone that we should remove their prostate. We're doing a series of phase 2 studies to evaluate promising systemic combinations, and there are already 5 prospective trials that are available. MD Anderson has one that is becoming a cooperative group trial now. They allow either surgery or radiation, clinical endpoints. So there are a number of these studies being done. So in summary, radical prostatectomy is being used more commonly in high-risk disease, clinically localized. It provides excellent local control. and certainly has excellent, at least prostate cancer-specific mortality outcomes. Obviously, in high-risk disease, surgery alone is often inadequate, and we need to define better neoadjuvant and adjuvant strategies to improve outcomes. And certainly the future will lie in what we've heard about in multiple other studies, better characterizing the risk of the cancer and then adjusting therapy based on that risk for the appropriate combination. Thank you very much.